Sodium zirconium cyclosilicate in hyperkalemia. Definition: sodium zirconium cyclosilicate is a potassium binder that is intended for the treatment of hyperkalemia. Hyperkalemia, the term used to describe the excess of serum potassium, predominantly affects those with acute or chronic kidney failure.
Potassium. What's the role that potassium has in the body? The major role that potassium has is it stimulates the nerves and conjunction and muscle activity. And all this is excreted from the kidneys. So if something's wrong with the kidneys, it's going to affect the potassium. Now, depending on what textbook you have, depends on the lab values. This one I found pretty universal. So it's potassium 3.5 to 5 milliequivalents per liter. Now with potassium, you have to watch for the potassium levels with digitalis, diuretics, and IV fluids. This potassium is found mainly in the intracellular fluid as opposed to sodium, which is mainly found in the extracellular fluid. So with potassium, you do have to watch out if you have too much potassium, so that would be over 5. And what would cause too much potassium? One thing, if you're already taking potassium, you could be taking too much of it. You might be taking too much of the potassium supplements, which could cause hyperkalemia. Or, again, since it has to do with the kidneys, where it's excreted from, you might have renal problems. So those are the two main things that could cause hyperkalemia. Now, some of the signs and symptoms, these are pretty basic: nausea, vomiting, diarrhea. Then you also have irritability, anxiety, abdominal cramps, weakness, dysrhythmias, which is irregular rhythm. And again, since this has to deal with the kidneys, if you have too much potassium, your urinary output from renal failure is going to decrease. So you'll be urinating less because of renal failure. You'll also have muscle twitching, and if you have too much potassium, your blood pressure will be low. And then there's also the flat P wave when you're doing the ECGs or EKGs. Now, the way you want to fix this or treat it is you want to see what's causing the excessive amount of potassium. If they're taking supplements, then of course, you want to advise them not to take it or as often, or follow the directions. You also want to monitor the heart. Now, if you have too little potassium, which is hypokalemia, kind of the same thing as far as symptoms. You're going to have nausea, vomiting, diarrhea. Another thing that causes hypokalemia is an NG tube suction, diuretic use, medical problems. So again, it's going to have to deal with the heart, respiratory, or muscular. So that's what causes the hypokalemia. Now, some of the signs and symptoms, again, nausea, vomiting, some muscle weakness, weak thready pulse, decreased bowel sounds, decreased intestinal motility, and again, that's why you have the decreased bowel sounds, decreased reflexes, and decreased muscle tone. If on digoxin, you want to monitor the pulse because low calcium levels can cause dig toxicity. Now, if it's too low, it could be life-threatening, or if it's too high, it could be life-threatening. So if the average is 3.5 to 5, so if it's too low, it's going to be 2.5. If it's too high, it's 6.5. So potassium is really, really important to always check the levels. This was kind of like a brief overview of potassium, the hyper and hypokalemia. I'm going to make another video that's more in depth. It'll have a lot more information. If you found this helpful, let me know in the comments below. If you liked the video, of course, please like, and please subscribe. That way I know that my efforts are being appreciated. Thank you guys so much for watching.
Applications in medicine. It is intended for the use in patients with acute or chronic hyperkalemia to restore and maintain normal serum levels of potassium.
Okay, our next patients dealing with hyperkalemia, which is the condition of having too much potassium in the blood. And in this condition, you see blood potassium levels that are generally greater than about 5.1 milliequivalents per liter. And the individual in this case is feeling quite uncomfortable, fatigued, and in terms of the heart, there's irregular pulses, a widening QT wave on the EKG, so that indicates the risk for cardiac arrest. The stomach, very uncomfortable. And you see GI upset, which includes diarrhea. From here, the loss of potassium, or excuse me, the excess of potassium can go on to produce tingling and numbness in the extremities, and then muscle cramps and weakness in the legs. The kidneys are the next thing we're going to talk about being affected, and they begin to fail. So the consequence of that is change in the amount of urine output. Question: what are the nursing actions? Excellent cardiac assessments. This patient may even be in a monitored unit. Frequent neuro checks. Accurate intake and output. The use of potassium wasting diuretics like Lasix, and the restriction of dietary sources of potassium. So this person's not going to get that extra orange juice or banana.
Pros. It will be the first treatment available that specifically binds potassium ions, leading to their elimination from the body. The potassium binding capacity of sodium zirconium cyclosilicate is 9 times that of organic polymer resins. Cons. Sodium zirconium cyclosilicate is currently in one phase 3 clinical trial, testing the safety and efficacy of its long-term use. Most common adverse effects were diarrhea and urinary tract infections at all doses, and placebo in both phases.
So why is it reading a heart rate of 215?
Oh my God, wow, they stuck you up on.
I think it's picking it for T waves as well as the QRS complex. So thinking it's by Jimmy.
So you said the potassium, her potassium is 8?
Greater than 8.
Greater than 8.5.
Above what we can read.
All right,
Yeah,
Tony,
and she's got it, and she's got good pasture syndrome.
Sorry.
Two back carb, 10.
All right, I have a 20 on the inside of our rest.
So William, how are you treating this?
2 grams of calcium, 2 grams of bicarb, an amp of D50, and then 10 units of insulin IV.
Okay. It'll be interesting to see what happens to this QRS. Yeah.
You getting
Tell me when I can open this.
You can open it.
Yeah,
Will you back up a little
2 grams of bicarb, an amp of D50, 10 units of insulin. And I think that's chloride. That's calcium chloride that's going there, right?
Something's fine.
Oh, it's
I peased him. Thank you. And somebody left the Pixis open, and I closed it. I signed off the phone.
What are you doing? Have you done
I've done the insulin pen.
Okay.
What you doing?
nothing?
I'll tell you what.
I think you're getting real-time narrowing of the EKG
I
up
have
there.
them right there.
Are you trying to come and get it?
Yeah, I'll tell you.
I love you
Is
too.
it tightening up for you?
I think it's tightening up.
You want me to write?
Yeah, now you're down to her peak
I know, it's
T's.
fine.
Yeah.
We're gonna need some more blood though.
Look at that. Look at
That
that.
20 will probably pull back.
Look how fast you're
We got
changing
20
that.
in a row. She's already looking better. So insulin's in.
It's going to the hand,
You want to
right?
get some flushes?
Okay, one by first, the other
Hold
by
on,
first.
we got to flush first before you do.
Where's my, you got a big 50. Think about my car.
Look at your heart rate coming down because it's not picking up the peak T waves
And the QRS.
and the QRSs, yeah. Your second ample bicarb?
This is the first amp.
The first amp, you're still giving
The
it?
other one was the dextrose. This
Oh, that was the glucose.
Mm-hmm.
So she's got calcium to start out with?
It's going in another line.
Calcium's going in one line, the D50 glucose or insulin, and
But what caused that rapid change up
I take
there?
them out and I fill them and I flip.
Was it
Calcium has just started. It was
Yeah.
the insulin
right, it's probably
and
the
the
insulin and
and
And it has
D50 because that shifted.
because that was already in? How long had that been in?
D50 was still being pushed, but it was almost completely pushed.
And the insulin was already in. Boy, that worked fast. I wouldn't imagine it that fast.
It's almost done.
Look at that QRS up there.
Well, no, don't throw all, I haven't scanned any of that. No, that's okay.
Hot off the press. Look at that. That is
I'm
beautiful.
gonna hit a weight, y'all.
What year is it? 2000 and what?
P waves. I still don't see strong P waves, but what's the story then on the potassium?
When her formal labs came back on her comprehensive metabolic panel, the potassium was 9.7. That was drawn after the treatments had been done, and we were watching her QRS narrow on the EKG.
Wow,
So it was actually probably higher than that when we started.
Okay, so as we treated her and the QRS was narrowing, we drew the blood, and it came back at 9.7
Yes, sir.
potassium.
Yeah, 9.7. So we're repeating our treatment at this point.
In Ecuador, the kidney failure is usually associated with severe hyperkalemia from the beginning of the damage. Approximately 1 million of Ecuadorians suffer from kidney failure.
Cellular. Now you got to take potassium and move it in the cell, and there's 3 ways to do it, folks. 3 ways. One is, we know this. We know anybody who's in a metabolic acidosis, this happens. Hydrogen gets brought into the cell, and it spits out potassium. But what if we put them into a metabolic alkalosis? Meaning that we give them a shot of bicarb, this is going to happen. Potassium is going to go back in the cell, and hydrogen is going to go back into the blood vessel. Step 1 is we can mess with their pH by giving them bicarb. We reverse this process. Step 2 is what I call osmolar shifting. Okay? If someone has a high osmolality, either because they're a diabetic and they're hyperglycemic, or we make them hyperglycemic by giving them an amp of dextrose. So we give them an amp of dextrose, we give them a shot of insulin, insulin goes in the cell, and it sucks potassium with it. So we have 2 ways right now to move potassium intracellular. We can change pH, or we can osmolar shift. The last one is right here, high-dose Preventil. I don't know the mechanism of that. I've heard people try to explain it to me. I'm like, I don't know. That's just one of those things that I just accept and know it's a mystery of the body. That's how I look at it. We know Preventil works. How well does it work? Don't know. How fast does it work? Not quite sure. How long does it work? I don't know. But it's an option, and it's a good option. And there's advantages to Preventil. Why? What is the advantages of Preventil over insulin glucose or bicarb? What has this one have that these 2 don't have? What do you think?
Conclusion. The results indicate that sodium zirconium cyclosilicate is a potent, selective potassium drug that corrects hyperkalemia within 48 hours. A clinically significant treatment effect was observed within 1 hour after administration. The decline in potassium level was rapid and dose-dependent, starting at a dose of 2.5 grams 3 times daily.
Hi, I'm Corey Slovis from Vanderbilt Emergency Medicine. When I think about Hyper-K, the most important life-threatening electrolyte abnormality is Hyper-K EKG. And most of the time, our therapy is going to be directed towards driving K right into the cell. The first way to do it is with glucose plus insulin. As you give the glucose and insulin, as the glucose is driven into the cell via the insulin, it's going to take potassium with it. And we supplement that with a beta agonist, usually albuterol, and it could be with ipratropium by mask. And in adults, most people use 15 milligrams. In somewhere between 20 and 30 minutes, these two therapies will drop your potassium by at least 0.5 and over an hour by at least 1.0. These are the two best ways to rapidly drive potassium right into the cell. There are three other ways. I want to talk about them a little bit. The first is bicarbonate. Now, bicarbonate works by exchanging hydrogen inside the cell for potassium outside the cell. When you give bicarbonate, it neutralizes the hydrogen outside the cell. Therefore, more hydrogen has to go out, K goes back into the cell. Bicarbonate is spectacular, but only if the patient is acidotic and significantly acidotic. So, glucose and insulin, albuterol, bicarbonate, only if acidotic. The dose of glucose and insulin, in general, is in a ratio of 5 to 1. So we normally give 50 grams of glucose and 10 units of IV insulin. 50 grams of glucose is going to be not 1, but 2 amps of D50. It's D 50% in W, 50 grams per 100 cc's. So 2 amps of D50, 10 units of IV push insulin. Keep in mind that in about an hour, hour and a half, you want to check your glucose because giving insulin can result in hypoglycemia later on. As far as the beta agonist, as I said, 15 milligrams, continuous mask. Bicarbonate, just like glucose, 2 amps or 100 cc's. Volume as saline is great, except most hyperkalemic patients have renal failure. Most people that are hyper-K with renal failure have volume overload. So talk to your nephrologist. You may want to just give 100 cc's to rev the pump, to drive K into the cell via the sodium-potassium pump. If someone has hyperkalemia with normal kidneys, maybe due to a drug, an ACE inhibitor, then you can give lots more saline because they'll pee it out. You put saline in the vein, they pee saline and potassium out. Fifth way, magnesium. We don't normally give magnesium in hyperkalemic patients, even though it drives K into the cell, because hyper-K, EKG, hyper-K is usually hyper-mag also. There are 5 ways to drive K into the cell. First 2, glucose and insulin in a ratio of 5 to 1. 2 amps of D50, 50 grams of glucose, 10 units of insulin. Be careful, an hour to 2, you might get hypoglycemic. Next, start them immediately on an albuterol mask, continuous inhalation, 15 milligrams. Those 2 things will drop K rapidly. Third, bicarbonate, 2 amps, 100 cc's. Bicarbonate only if acidotic. Fourth, volume. Give them a couple of 100 cc's of saline. Talk to renal first if they're a dialysis patient, especially if they're fluid overloaded, and almost all of them are. If they can make urine, saline is great. Saline in, saline and potassium out. Fifth, magnesium. We love magnesium. It drives K into the cell, but hyper-K, EKG, hyper-K, also hyper-mag. We've done 5 ways to drive K into the cell in under 5 minutes. Thank you.